Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article Intensifying Treatment for Childhood B Lymphoblastic Leukemia with IKZF1 Deletion Reduces Relapse and Improves Overall Survival. Results of the Malaysia-Singapore ALL 2010 study by Yao et al. My name is Dr. Michael Burke, and I am an Associate Professor of Pediatrics in the Division of Oncology at the Children's Hospital Wisconsin in Milwaukee, Wisconsin, USA. My oncologic specialty is pediatric leukemia. Although outcomes for children with B-Acute lymphoblastic leukemia, or B-ALL, have continued to improve over time, with overall survival rates now surpassing 90% at 5 years, certain subgroups of patients continue to have poor outcomes. Thus, identifying which patients may have higher risk disease at time of their initial leukemia diagnosis may help determine which patients should receive intensified therapy to improve these outcomes. In addition to the NCI risk status used to categorize B-ALL into either standard risk or high risk, defined by a patient's age at time of diagnosis and their presenting white blood cell count, recent discoveries in leukemia biology has led to the identification of a high-risk subset of children known as Philadelphia-like B-ALL. These patients harbor similar gene expression profiles as patients with Philadelphia chromosome-positive ALL, except they do not have the BCR ABL1 fusion transcript, which defines Philadelphia chromosome-positive leukemia. The majority of Philadelphia-like or PH-like ALL is driven by mutations that activate the JAK-STAT pathway, involving alterations of CRLF2, JAK2, and/or the erythropoietin receptor EPO-R. Other mutations identified within PH-like ALL include ABL class fusions such as ABL1, ABL2, CSF1 receptor, and PDGFR-beta. Patients identified as having NCI high-risk B-ALL and the PH-like phenotype have considerably greater risk of relapse and worse survival. The IKZF1 gene is another mutation that has been identified in ALL that confers a poor prognosis. Deletion of the IKZF1 gene, which encodes for the lymphoid transcription protein Ikaros, has been identified in patients with Philadelphia chromosome-positive ALL as well as PH-like ALL, and has been associated with relapse rates in the range of 50 to 60% in NCI high-risk patients. However, the identification of IKZF1 deletions in patients with ALL can be challenging, as it does not appear on routine cytogenetic assessment, but requires more advanced testing such as comparative genomic hybridization, CGH, RNA sequencing, or multiplex ligation-dependent probe amplification, MLPA. MLPA is a DNA-based assay that is rapid and affordable and can identify IKZF1 deletions, which, if identified, could be used to risk stratify patients to high risk in more intensive therapy. This screen method for IKZF1 deletions was used in the Malaysia-Singapore ALL 2010 study, recently published in JCO. The authors report on 2 consecutive studies in pediatric ALL, 2003 and 2010, where the MLPA assay was used to identify IKZF1 deletions. In 823 pediatric patients with B-ALL enrolled across these 2 trials, 109, or 15.9%, were identified as having IKZF1 deletions, 59 in the 2003 ALL study, and 50 in the 2010 study. These patients tended to be older in age and had higher presenting white blood cell counts compared to the patients without IKZF1 deletions. In the 2003 ALL study, where IKZF1 deletions were not used in risk stratification, patients with IKZF1 deletions reported significantly higher rates of relapse at 5 years, 30.4% versus 8.1%, compared to patients with IKZF1 wild type. When excluding the Philadelphia chromosome positive patients, IKZF1 deletion continued to confer a significantly higher rate of relapse in IKZF1 deleted patients, 20.5% versus 8%. What was striking in the manuscript that accompanies this podcast was the improved rate of relapse for IKZF1 deleted patients once IKZF1 testing was instituted in all patients up front on the 2010 ALL study and used in their treatment risk stratification. Children 1 to 18 years of age with newly diagnosed B-ALL were further risk stratified to high-risk therapy if they had an IKZF1 deletion identified by MLPA. This intensification of therapy based on IKZF1 deletion alone resulted in a reduction in the rate of relapse to 11.4% for Philadelphia chromosome negative patients with IKZF1 deletions. Although this was still a higher relapse rate compared to the 4.4% for IKZF1 wild type, it was a significant reduction compared to the 20.5% reported on the 2003 ALL study for IKZF1 deleted patients. This reduction in relapse resulted in an improvement in overall survival from 69.6% reported in the 2003 study to 91.6% in the 2010 study. To date, likely the most prognostic marker predicting relapse and survival in pediatric B-ALL has been the evidence of minimal residual disease, MRD, at the end of induction therapy as measured by flow cytometry or real-time PCR. However, the recently discovered molecular and cytogenetic lesions, such as those found in patients with PH-like ALL, which include IKZF1 deletions, can also identify patients at greater risk of relapse and worse survival. What Yao and colleagues identified in their report was that risk-adapted therapy, as in the case of identifying IKZF1 deletions, and intensifying therapy can improve outcomes in children with B-ALL. Even when they accounted for patients with IKZF1 deletions who are MRD positive at the end of induction, patients who received intensified therapy appeared to have improved outcomes. In summary, the report by Yao and colleagues has shown the feasibility of prospective IKZF1 screening within a multi-institutional pediatric ALL trial where adverse outcomes could be mitigated based on further risk stratification and treatment intensification for IKZF1 deleted patients. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.